I think we'll start and allow people to come in. It's already 8:01. Good morning and welcome to the Hamilton Health Sciences Department of Medicine medical grad round. Just to start with a reminder of housekeeping issues. If you have a question, please put it in the Q&A section, and we'll have time at the end to go through those questions. And if you have any comments or you want to start a conversation on the side, please go to the chat section for that. It is open as well. Today, we're pleased to have Dr. Alison Fox-Robichaud. I think all of us know Dr. Fox-Robichaud. She's a professor of medicine at McMaster University and ICU physician at Hamilton Health Sciences. She's the director of medical education at Hamilton Health Sciences as well. She's a scientific director of the CIHR-funded Sepsis Canada. This is a research collaborative of 190 scientists, knowledge users, and patients and family partners. She is the inaugural president of the Canadian Sepsis Foundation and a member of the board of the Global Sepsis Alliance. In 2018, Dr. Fox-Robichaud was awarded by Global Sepsis Alliance an individual award for her sepsis leadership. We all know Alison has been a great clinician and scholar in this field and is hugely published. So we're pleased to have Alison today speaking to us about reducing the impact of sepsis from hospital to a nation. Alison, please go ahead.
Thank you, Khaled. Good morning, everyone. I'm going to take us through a little bit of a journey in the next little while, and I'm hoping I've left enough time for some good discussion and questions. At the end of the rounds, I hope we'll have a better idea of the definition of sepsis, how it's evolved over the past 30 years or so, understand the importance of accurate documentation, describe the impact of sepsis on our healthcare system, not just within Hamilton, but with the province and beyond, and identify potential solutions to address some of the gaps that I'm seeing locally, but also our national sepsis strategy. The sepsis was probably known since the ancient Greeks. They had this word septium meaning to rot, but the first modern use we know of was in the 19th century. In the beginning, or sort of mid-20th, late 20th century, there were a group of physicians, mainly critical care physicians, who got together to create what we called consensus definitions. The first ones were published in 1991, 92. The second consensus came in 2001. It really was just a minor update with a little expansion of some of the organ dysfunction criteria. And then in 2016, a real reframe of what the consensus definition for sepsis is. And we really progressed from that 1991 consensus definition, where the use of SIRS, the terms severe sepsis and septic shock, to the 2016 consensus definition, which really gets rid of SIRS and turns it on its head to define sepsis as the following: life-threatening organ dysfunction caused by a dysregulated host response to infection. And that 2016 definition did a couple of things. It really linked the fact that what we're seeing in sepsis is this progression from infection to organ dysfunction. It introduced the use of a scoring system that we've had since the mid to late 1990s called the SOFA score. And it made the clear recognition that sepsis is life-threatening and still a source of significant mortality. The question has come, is SOFA the correct tool? The SOFA score, as you see in the paper on the left, was created by primarily a group of intensivists and published in 1996. At SCORE, despite the fact that we don't always use blood gases and we don't always measure bilirubin and we don't use dopamine as our primary pressor anymore, has really not gone under any significant revisions. However, it has been validated in separate studies, and the paper on the right is just one example of a number of papers that have come out after the sepsis 3 definition, talking about the prognostic accuracy of SOFA compared to SIRS, and the Q-SOFA, which we can talk a little bit about, came out in the definition, which is really 3 criteria. And as you can see on those ROC curves, SOFA, both with crude and adjusted mortality, clearly outperforms either the SIRS criteria or the shorter Q-SOFA. And so it definitely has some validity, at least in North American populations. But here's the challenge with Sepsis 3. The definition and the creation of the databases that drilled down into what was important were really first world. They were based on large databases out of the US and Germany. And that expert panel was definitely not equitable, inclusive, or included either middle or low income country data. The result of all of that was there was a number of women, particularly within the critical care community, that wrote letters to the editor and published position papers after that, because it was mostly, if you look back on those author lists as the definition, Deb Cook was the only woman in all of those years of defining what sepsis was. And so while SOFA has been validated, it's not been revised, and there's a lack of diagnostic tests. And so we often rely, as the cartoon show, on looking for organ dysfunction and on looking for signs. This little figure on the left really talks about the fact that we're trying to educate our patients in many areas of the world about what might sepsis be, but we haven't made the link necessarily between patients and clinicians. And so some of the work, I'm just going to briefly highlight a little bit of the work in our lab, but this is a figure that one of my graduate students has been working on. The real challenge is trying to figure out what is that critical time zero from when a patient develops an infection until they actually have sepsis. And as we're starting to understand this clinical progression, which may be, and is lots of evidence to support, associated with increasing variation in vital signs as measured by early warning scores, which will progress to organ dysfunction as measured by the SOFA, there is a physiological process that's ongoing that involves inflammatory cells such as monocytes and neutrophils and platelets. We starting to believe, and work from colleagues in Calgary and some of our work locally has shown the importance of the production of neutrophil extracellular traps, these spider webs that neutrophils and other inflammatory cells can throw out in an attempt to trap bacteria. But it has a double-edged sword in that histones in the circulation and cell-free DNA promote clotting, decrease protein C levels, and injure endothelial cells. And importantly, we know that platelets are a part of that coagulopathy that we can see in the microcirculation in experimental models. And there may be some role for ADAMTS13, which we've traditionally thought as more related to diseases like TTP. The other thing that we're starting to learn is that not all sepsis is equal. And this is just highlighting one of a number of papers recently in the adult population that talk about what we call sepsis endotypes, which can vary from minor organ dysfunction to individuals who get progressive disease with underlying organ dysfunction, such as people with chronic kidney disease or COPD, to people that have more abnormal labs and lung dysfunction. And the most profound that we see is septic shock with associated profound shock liver. And as you could expect, as you go from the alpha to the gamma there, and delta, the mortality certainly goes up as well. I want to highlight why we think this immunothrombosis, or this link between inflammation and coagulation, is so important. And it really has to do with one little body that sits within endothelial cells called the Weibel-Palade body. And we know the Weibel-Palade body is important for releasing van Willebrand factor, but the other thing that's released from theirs is P-selectin, the molecule that initiates leukocyte recruitment from the vasculature into the endothelial surface. And so my graduate student for the past 2 years has really been taking blood samples from our emergency department patients, and we don't have time today to talk about it, but she's clearly showed that early on in patients presenting to our emergency departments with early sepsis, in which our colleagues say that their patients are septic, ADAM-TS13 goes down, as does protein C. So how common is sepsis? Well, this is the Global Burden of Disease study published in the Lancet just this past year. And it used a combination of techniques, both coding data where it was evolved and mortality data where that was evolved, databases that are starting to evolve out of Africa. But it shows in this graphical form that the incidence of sepsis really per 1,000 patients varies around the world. And not surprisingly, sub-Saharan Africa, in which the healthcare systems may be limited, has the highest incidence. But there are still problems in South America and otherwise. Canada looks like it's relatively favorable, as does parts of Europe. And that may be true, but we're limited in Canada by the amount of data. The other thing we know is that there is that sepsis, among all other causes of illness, far outweighs injury and communicable diseases globally across the world, irrespective of age. And so when we think about the fact that life-threatening organ dysfunction and the cause of death as an infection, it's clear that infections outweigh most of this around the world. But the challenge is a coding challenge, and there have been multiple papers, but I highlighted this one that was just published 2 years ago out of the CDC, talking about how we use clinical data versus ICD-10 codes versus administrative or electronic clinical data as we move to more complex EHRs. And the conclusions from this paper is the variacy, because this was the US looking at claims data versus clinical data, suggested that using objective clinical data may actually be more meaningful when comparing hospitals, because when they actually drilled down, the reporting of mortality based on ICD-10 codes was not equal to what they did when they looked at clinical data. And here's the challenge. The coders really have a difficulty sorting out that clinical course in hospital. They may not be able to review the entire course. The definitions of sepsis are unclear, and currently ICD-10 doesn't always get all of the sepsis criteria. I'm going to come back to this physician documentation challenge, and it was one of those reasons that I really wanted to speak to this group on this topic, is because as we've been auditing some of our charts, we've clearly recognized that how we document sepsis in the chart and how we misdiagnose sepsis in the chart becomes a bit of a challenge. So how expensive is sepsis? This data on the left is US data showing that from their quality reports of 2013, and I can't imagine it has gone down, particularly during the pandemic, but showing that sepsis far outweighs the costs compared to myocardial infarction, simple pneumonia without evidence, congestive heart failure, or other causes of respiratory failure, to the tune in the US of about $20 billion. And even if you took that and moved that decimal point by 1, it would still suggest, despite the data that we currently have in Canada, that sepsis is expensive as well. And so I'm very pleased to highlight this paper that has just come out this month in Critical Care Medicine. It's Ontario data, it's ICES data, and using a propensity matched data cohort, I think there are a couple of things to highlight from this paper. First of all, at least using this in Ontario, about 15% of the sepsis we're seeing in the province, and this was using sepsis 2 definitions, is sepsis. But more importantly, the costs were significant compared to every other admission in Ontario. And so in Ontario, just looking at this paper, costs about $1 billion a year. And we're about to have a big press release to highlight this to the provincial government. But I want to highlight a couple of things from this paper. The first is that the hospital length of stay on average, even adjusted for comorbidities and a few other things, was on average 12 days longer, 12 and a half days longer than any other admission diagnosis. And an ICU mean length of stay for these septic patients above that of about 5 days. Importantly, these patients had significant hospital readmission, both at 30 days, 1 year, and a full follow-up 5 years later. The result of all of this is that the index hospital cost compared to their match controls for other admission diagnosis was on average somewhere around $23,000 using 2018 dollars. At the first year, that was $30, but that persistent cost above all other admission diagnosis in Ontario ranged between $10,000 and $13,000 per year. So the cost of sepsis doesn't just occur during that index hospitalization or the first year, but definitely beyond that. And this has a huge impact on our survivors. I'm highlighting a few people from our network and some of our local people. Some of you may recognize Denise, who's an ICU West and a sepsis survivor. Up in the corner here is Maddie Fairman, who was one of our ICU nieces, survived not only a community-acquired pneumonia. Maddie has her own YouTube video that the BHSC students created. It's really a wonderful video. This is Barbara Dolinsky, who is our patient partner on the harm reduction work. Ray Schachter is was a member of the GSA and is a member of the board of the Canadian Sepsis Foundation and part of Sepsis Canada. Kirsten and her daughter Ellie had sepsis group B strep associated with labor, and both she and her daughter have significant consequences from that birth. Marie Maxime is a dietitian who also had pregnancy associated sepsis. And Christine Caron has been a really big advocate. Christine lives in Ottawa. She is, like many in her community who get profound clotting associated with sepsis, a triple amputee as a result of septic shock. This paper that was published about 2 years ago really looked at, for one of the first times, what survivors of sepsis are experiencing. And I want to highlight a couple of things that are markedly worse after sepsis. The first is that fatigue is a huge thing. Cognitive dysfunction is a huge problem with these people after sepsis. Maddie will tell you that she used to have a photographic memory, and which was a huge benefit for her as an ICU nurse. And she lost that as a result of her episodes of both community-acquired and hospital-acquired sepsis. The ability to walk and actually complete walk is something that we've known for quite a while, but validated here by our survivors in this international survey. So what do we know about the treatment of sepsis? I've highlighted the 2016 Surviving Sepsis campaign, and you can see that McMaster plays a prominent role in this author list. Walid Alizani, for the past 4 years or more, has led this, but Bram is part of this process, as is many of our other colleagues here who've contributed to the systematic reviews that are part of all of this. I've seen a pre-copy of the what will become the 2020 Surviving Sepsis campaign guidelines, again with some revisions based on data coming forward. But what the Surviving Sepsis campaign does is it really highlights some things that are important. And this figure is from one that particularly highlights both the inpatient and the outpatient response to sepsis. And it starts with measuring things. Really, lactate is quite non-specific, but it does give us at least some idea of tissue perfusion. Getting blood cultures if you can before administering antibiotics, certainly looking for that source of infection, administering broad spectrum antibiotics. Unfortunately, we could spend a whole nother hour talking about the gaps in rapid identification of pathogens, particularly bacterial pathogens, and we've got some work ongoing at the university to improve that. There are now some PCR-based techniques in certain fluids. It's difficult in things like sputum, for example, to be able to pull out the specific pathogen. I'm hoping we'll start to see some revisions of the fluid story, but it's still important to remember that on average, people coming in with septic shock particularly will require significant volume of fluid in 30 mils per kilogram of crystalloid, which for the average person is 2 or more liters for hypotension. And we're particularly looking for those lactate up. The newest definition actually has lactate greater than 2, which is at the threshold for normal in our labs. And then certainly supporting blood pressure. Data from Francois Lamontagne would suggest that 60 may be adequate rather than 65, but using vasopressors early to support blood pressure and tissue perfusion. So in general, about 80% of the sepsis, 75 to 80% of the sepsis we see is community acquired, and patients are admitted through the emergency department. However, clearly about another 20% is hospital acquired, and this is expensive and can be life-altering. Data from previous studies has shown that if you acquire a second episode of sepsis when being admitted to the intensive care unit, that mortality can approach 100% during that hospital stay. The causes of in-hospital infection are multitude, and a lot of it is related to the things that we do to our patients, the tubes and lines we put in, whether they've undergone a surgical procedure, elective or not, the immobility that occurs after or during a hospitalization, and certainly their underlying conditions. And data that we pull every year suggests that HHS spends approximately $13 million a year for hospital-acquired sepsis conditions. And so this is one of the reasons that we have been trying to address that gap. So the data is retrospective and reported by CIHI, and CIHI has its own issues. It certainly misses the neonatal population, which is not reported. CIHI data does not include Quebec, so we don't have necessarily accurate data. It absolutely relies on your and my accurate documentation in the chart about who is septic. And as I've mentioned, determining who is septic can still be challenging, and the current ICD-10 codes certainly have gaps. And finally, not all hospital-acquired sepsis is preventable. And many of our patients are immunosuppressed or underlying chronic diseases, and infection leading to sepsis-associated death may be a final pathway. However, when we look at HHS, and this is the 2018-19, I tried to go on to CIHI, but the webpage was not working to pull up this data for the 1920 yet. It should be available shortly. Hamilton Health Sciences has consistently been amongst the worst in the country. Now, if you compare us to centers like Sunnybrook and others, they are up there as well. But looking at teaching hospitals across the country, looking within our own LHIN, Ontario, and indeed Canada, we tend to have more in-hospital sepsis per 1,000 admissions. Is that because we're such a big multi-center? Maybe. Is it because we go from cradle to grave and we have trauma patients and oncological patients, and unlike many other multi-center hospitals may not have that broad spectrum? It's unclear. But we wanted to drill down a little bit into what was different about HHS and our sepsis. So for the last while, my postdoctoral fellow has been working on this. But I want to look at this trend firstly from 2018 to March of this year and show the fact that we've had a gradual downward trend in the amount of sepsis as HHS with these little spikes. And I would have said, oh, maybe this is flu season, and maybe again, this was flu season last year or the start of COVID. But it's clear we've had a downward trend. Is this only been to sepsis education? No. This has probably been a collaborative effort because, as many of you may know, there's been focused on catheter-associated urinary tract infections, trying to get those catheters out, using best practice about how we transport patients. There's also been significant work on central line infections, best practice in terms of insertion, best practice in terms of maintenance, and getting those central lines out as soon as possible. And finally, there's been work by the surgical team looking at surgical site infections, getting timely antibiotics in the perioperative period. And that team has actually been focusing recently on looking at the deep abdominal infections associated with large organ sepsis. But we audited those cases from January 20 through March. There were 52 of them. And indeed, during that audit, 17% of them, there was no evidence of sepsis. They were infection, but weren't septic, or in fact, they had other illness. And this becomes the first coding challenge. We often write suspected sepsis on their emerge admission, or we write it when they develop it in hospital. And we forget to say, oh, we found another cause, and write back in the chart, oh, this was not sepsis. Nor do we necessarily put it in the discharge summary, this patient did not have sepsis or did have sepsis, and what was the source of infection. So we had a group of patients in which 83% of them were confirmed sepsis, but then when we drilled down into them, only 8 of those patients were actually hospital acquired and preventable. So what were the hospital acquired? So 19 of them were not even hospital acquired. And this becomes a challenge for the coders to say, you really need to say, I think this was community acquired, or this patient had a recent admission, they came back in, and therefore this may be hospital acquired sepsis. And then there was a proportion of those that were truly hospital acquired infections. And again, just looking through this small audit, the Foley was a problem, certainly. And Carissa Caron, who is the chief of nursing practice, has been going around as part of all of this work, talking about the Foley catheters. Can we get them out? And we've seen great work. One of them was ventilator-associated pneumonia. We have a provincial requirement to report ventilator-associated pneumonia, so it's not just focused in the ICU, but aspiration during intubation. You can see the journeys through the ICU, a wound infection and a central line infection. And we've actually been pretty good in the hospital in the last little while. I know Children's Hospital, for example, went almost a full year without a central line infection. And they've been really working very hard to prevent central line and other hospital-acquired infections. So when we reviewed those 52 patients, 43 of them had sepsis. Of those, about half were hospital acquired, 20% were not, 19 of them were not, and only 8 of them really preventable. And so it really gives us the question. I've gone back to Marcelo to say we really need to drill down as, were they a terminal event? Was there anything else we could have done? Physician education is important, and I would challenge us to really think about that accuracy. What is the source of infection to improve our coding accuracy? And I'm going to challenge the residents a little bit to please stop using 2 terms, pneumosepsis and urosepsis. We have a lot of bacteria. Is that truly septic? Did those patients truly have urinary tract infection with organ dysfunction? And then pneumosepsis, is it pneumonia? Do the patients have new onset or worsening organ dysfunction compared to their baseline? And what is the source of that? Because as some of the attendings will know, we get these reports back. Okay, was it viral pneumonia? Was it bacterial pneumonia? So going forward, we really need to separate that chi-hi, which is not going to go away and will be reported from what is going on. And so you may have seen these posters around the hospital. This is part of our harm reduction work. Posters have a limitation in terms of their education, but they do maybe raise some awareness. And this is work done by one of our undergraduate students who's now a PA student. where writing sepsis is important. It'll be important for coding. The more we code accurately, definitely gets appropriate funding. And as we saw here, sepsis cases cost us on average well above that average that was reported in the ISIS data. So $77,000, right? And it means that we've got equitable resource allocation. So patients use significantly more resources and a 4 times longer length of stay. So although QSOFA has its limitations, it certainly triggers things. And so we've used this symbol around the hospital to really think about the quick SOFA. If your patient's got even a little bit of hypotension, altered mental status, a bit of tachypnea, I still remember early days of race when just looking at that tachypnea, and we still know it's the most poorly documented vital sign, but just looking at our patients in the morning, absolutely, if their Hughes is elevated, then they've got proven or suspected infection, but look for these other signs of organ dysfunction. Then consider ordering your antibiotics stat. We're going to talk about that. And patients who are septic, and definitely patients who are in septic shock, require antibiotics within 1 hour. Otherwise, the mortality goes up. So we've done one other quality project here, and really it's looking at the time to antibiotics. This was work done by Neil Irfan, who's the ID pharmacist at the General. And Neil took a pharmacy intern and really looked over a period of time in 2018, on how long it took to get IV antibiotics when there was a chain of antibiotics on the ward or a new start of an IV antibiotic. They used QSOFA just because it was easier. The non-ICU sected. We know QSOFA is not necessarily used to diagnose, but it was a good screen. And it certainly becomes a predictor of mortality. So if you have a QSOFA 2 or 3, it implies a 3 to 14-fold increase in mortality risk based on the sepsis 3 definition. And so here are the findings. Just an equal amount between the General and the Juravinsky. The average age was in the mid-60s. Most of them came from the medicine ward, but there was definitely a scattering across the hospitals. There were a variety of antibiotics used. Our favorites seemed to be Piptazo, Vanco, and ceftriaxone. There were a number of indications for the new start of antibiotics, a new diagnosis of bacteremia, surgical site infections, urinary tract infections, pneumonia it was the spectrum. But here's where it gets challenging. The total average time to deliver the antibiotics was somewhere around 3 hours, irrespective of site. And here's the challenge. The prescriber writes the order, the nurse transcribes it, the pharmacy enters the order, the technician fills the order, and eventually it gets administered. And when you break down these times, you see that particularly with our sickest patients, it was still taking 2.5 to 3 hours to get those antibiotics. And so what Neil and the group have been doing on 7 West to start is really doing some process observation about how we can reduce that time to antibiotics. And I'm hoping we're going to have something shortly. We've got a meeting coming up next week to see about how we can spread some of this to make sure. The one thing I would suggest is if you think that patient needs new antibiotics and they're septic, write stat. Make sure it gets delivered and make sure you speak to the bedside nurses the importance of getting this antibiotic in as quickly as possible. So we've looked at a number of hospital-acquired infections, but the one thing we haven't really drilled down into is pneumonia. And so the quality experts have been following this as part of NESQIP. And they did, as part of that environmental scan, the top 2 reasons for antibiotic were sepsis and pneumonia, or starting antibiotics. The medical floors were certainly implied in all of this, and we've been just sitting under the radar for NESQIP in terms of being either worst or nearly worst for the past 3 to 4 years. And as I said, we haven't really been thinking about pneumonia as a cause of hospital-acquired sepsis. So when this was drilled down in the NISQIP data, it showed that, we had a number of patients who had sepsis at both sites, and pneumonia was a prominent feature of those patients in the 2018 data. There were implications for length of stay, and those patients who had hospital-acquired pneumonias had lengths of stay up to 2 weeks average longer, irrespective of when the patients were there, okay? And so the focus, I would think, is thinking about prevention. We haven't had incentive spirometers in my mind, certainly as long as I've come to HHS, and that's been 20 years now. But certainly this eye cough, including the use of deep breathing or incentive spirometry, appropriate oral care, which sometimes I think we forget for our patients who are not always able to do that. Getting out of bed and walking, and keeping the head of bed elevated. We know this in critical care, how important it is to keep head of bed elevated, particularly at those patients at risk of aspiration, but also teaching strategies, particularly in the peri-op period. So the last thing I want to introduce out of the quality work, and I'm just keeping track of my time here, is in collaboration with IT, we've been working on a tool to prospectively track patients for sepsis in real time in the hospital. And some of you may have seen this before. I've presented it to the ID group and the Council of Chiefs. But I want to show what's sitting in the background of Meditech right now and what we're hoping to launch live next week. We will give access of this to all of the physicians at HHS. We're going to give it access to the charge nurses and the managers on the unit so that they can track on their individual wards. We have a working document, so how you can access this and look for patients. But this is a screenshot of this board showing that I could tell you at any one time who is septic in the hospital. We worked with a company called Diatrix to build this, and you can see that we pull up the SOFA score and the Q-SOFA. We can tell you how long that patient's been septic, whether they've been in septic shock, their location, anything around allergies, and their post. You can see that they come from a variety of wards, this screenshot that I did several months ago. And my postdoc has drilled down for this, and it appears that this prospective, minute by minute, it's updated every 4 minutes in the chart, has a sensitivity of 93% and a specificity of about 80% compared to accuracy for others. And the limitation is Q-SOFA, really, in terms of the specificity, or the SOFA score, because SOFA score, although it was thought to be particularly for sepsis, doesn't preclude other causes of organ dysfunction, including myocardial disease or other illnesses. So with all of that work, I'm going to turn it now to why we're doing all of this nationally and why it's so important. In 2016, the Global Sepsis Alliance took to the World Health Assembly a plea to make sepsis a global health priority. Konrad Reinhardt, who's a colleague in Germany, has been really passionate about this. This has been raison d'etre, and Konrad's recently just stepped down as the president of the GSA, and I'm pleased to say Tex Gassoon, one of our pediatric colleagues from Vancouver, is now the new president. But this paper really highlights this as a global health priority. And the World Health Assembly took that on and told all of their member states, including Canada, to develop a number of things, including a national policy to improve the recognition of sepsis, clean water. I can think about our Indigenous communities, promote public awareness. We know that probably less than a quarter of Canadians actually know what the word sepsis means. Training healthcare workers, improving ICD coding to allow for better assessment of burden disease and antimicrobial. ICD-11 is out there. It's supposed to be better for sepsis, but it's probably going to take another 2 years before it's part of our usual raison d'etre. and engaging in activities. World Sepsis Day is September 13th. This year it's going to coincide with the World Congress of Critical Care, and we've got plans to really highlight that. So you can see a lot of government involvement here. I would say that one of the things that limits us compared to countries like the UK, where the National Health Service has really, and working with the UK Sepsis Trust, has done huge jobs in making sepsis awareness a priority at all levels, including in schools. We are limited to a certain extent by the Canada Health Act and the fracturing of healthcare across the country. So Sepsis Canada came out of a call on World Sepsis Day 3 years ago now, for us to set up a Canadian research network. It was a competitive process. It involves the Institutes of Circulatory Respiratory Health, III, Diabetes and Metabolism, because of an ask around looking at patients who are obese, and population health. We now have some branding and logo. You can follow us on Twitter. And we took what was a long title for the CIHR grant down to Sepsis Canada, just a little catchier. And the government kindly gave me and our team $5.7 million. We had a matching other $1 million. Our team is led by myself and Francois Lamontagne, who trained with us here at MAC, but is a professor and a clinical trialist in Sherbrooke. We hired and borrowed from our critical care colleagues in Calgary, and Nubia Zapata as our managing director, who runs the day-to-day and has been an absolute charm to help us keep us on track. And we hired part-time Bree Chauncey here at McMaster, who's a communications assistant, to help get us all up and running. We have a lot of support and a lot of partnerships. I want to highlight the trials group and our translational biology group. The Critical Care Society, the UK Sepsis Trust has been part of all of this. But we are really a coast-to-coast partner organization with hospitals and others across the country. We have some burgeoning industry support. You may recognize the name ThoughtWire, who's been involved in some of our handheld projects in the hospital, and BD, who has really taken this on as a national and international policy to support. So our mission, we created a vision. This vision was done with our patient partners to suspect sepsis, save lives, and support recovery. Our mission is really to understand the causes of sepsis and improve the detection, management, and rehabilitation for all Canadians through research. It aligns with what the WHO has asked us. And we really have these 5 areas of focus: understanding the causes, improving, preventing sepsis, the detection, the management of sepsis, and our patient partners really have said this post-rehab is so important to them. We have an international advisory board led by our colleague, John Marshall, but includes colleagues from around the world. We have a patient council that really is taking off and will help determine some of our research goals. We have some other committees developing. The executive committee consists of Nubia, myself, and Francois, but we report to a steering committee, which are leaders of a number of the teams. When the grant was created, we based it, CIHR asked us really for a difficult challenge. They asked us not just to look at biomedical, not just to look at clinical, but truly to look at all of 4 CIHR pillars. So you can imagine pulling a diverse group of people, and it isn't just intensivists. We have geographers, we have ethicists, we have qualitative and quantitative methodologists. Our team 1 is really our population health team. They want to help better define what sepsis is in Canada using a lot of administrative databases and scoping reviews of the literature. Our team 2 is really looking at that knowledge transfer, both into the health literacy of our people across Canada, but also improving the health literacy of people outside of critical care. It's interesting, when I went through some of the objectives of training, I noticed in internal medicine, not once for the objectives of training for internal medicine is the word sepsis mentioned. So you mentioned infections, but not the word sepsis. There used to be on the old OTR Eurosepsis, but that was the only term that was mentioned. Team 3 is really a bench to bedside. It includes our biomedical scientists, but also our clinical trialists. And we have these overarching capacity building through a training program. It needs to be patient and family centered. We've worked really hard, and CIHR has asked us to build an equitable, diverse, and inclusive. And our steering committee has had a particular biopic and gender framework, but we know we've got work to do that, particularly around disadvantaged groups in our Indigenous communities. We want knowledge exchange, and we definitely want research excellence out of all of this. So our 3 teams really have these themes, looking at the burden and all the way to cost-effective therapies, with these overarching themes going through. Our patient council is led by Christine, that triple amputee, and Christine Russell, the young woman who she and her daughter had peripartum sepsis. I think we have 24 people there. We've done some branding. We produce a monthly newsletter. One of my graduate students is going to get us on Instagram, but we've created a style guide, and our website is now live, sepsiscanada.ca. We have a communications working group. You'll see a few of our colleagues there. Teresa's experience, particularly in the social media, has been very important. Blair's now doing his critical care training in California, but his expertise, for those of you who don't know, Blair was an emergency resident through our program, a paramedic before that, and did a fellowship through the Monk School of Journalism. Kathy Hendricks lost her father to recurrent episodes of sepsis associated with a malignancy. And Grace is a graduate student in Ottawa. So this is our working group here. When we put the grant in, we listed a number of projects that we're currently working through a process to start moving the money. COVID has definitely slowed us down, but I'm going to go forward and highlight a couple of things. We've been refining this process. CIHR told us we already gave you the money, don't reinvent the wheel. So we're just refining that, having some stakeholder engagement to make sure we've done that broadly, and getting approval by the steering committee. This is our process we've been working through for the past couple of months. The training program needs to be cohesive. We're looking to create a model where we really train people to broadly understand all 4 pillars of health research, engage all 3 teams. And we've even been working with a fantastic program in Calgary and our own program here at McMaster to train patient partners even as scientists. I want to highlight a couple of things that have been ongoing with the network. You may have seen the recent announcement about the Canadian Network of Networks for COVID, led by a dear friend and colleague, Rob Fowler, who's the current president of the Canadian Critical Care Trials Group. Sepsis Canada has played a big role in that in terms of partnership. And Francois Lamontagne is really looking at expanding our trials network across the country so that we have not only the usual academic centers, but community centers involved as well. And highlighting the work of a small but dedicated group of young investigators on our national preclinical sepsis platform. One of the biggest gaps in getting from bench to bedside is a lot of individual labs, and that translation gap has been limited by individuals using healthy mice for the most part. And so our national preclinical sepsis platform has actually had 4 publications and I think 4 grants off the ground before anybody else on our network, looking at using clinical trial formats for multi-center preclinical studies of sepsis models. And it really has been quite exciting, the work that this group is about to start. So in conclusion, I think I've left us about 10 minutes for discussion. Sepsis is globally the most important cause and common cause of illness and mortality. It may not be in Canada. We have a lot of other chronic illnesses, but I think it's one of those ones that we really need to think about. It's costly for the health system. It's costly for the survivors. There's, that global data clearly showed that the 18 to 65-year-old group has a lot of comorbidities and chronic issues. whether it's limb loss, whether it's the ability to return to work, whether it's recurrent bouts of sepsis because of the immunosuppression from the initial episode. Hospital-acquired sepsis can be reduced through strategies that address the most common causes and QI process that follow guidelines. Accurate documentation of sepsis and when it's not sepsis is really important. And I'm hoping that our national research strategy will address all 4 pillars, engages more than 190 patient scientists and their families, and a new generation of sepsis scientists. And with that, I'll open it up to questions. And I need to thank all of the collaborators and co-investigators, the graduate students and postdoctoral fellows, and certainly the members of our harm reduction committee for their hard work as well. And with that, I think I'll stop sharing, Khalid.
Thank you so much, Alison. This was like an outstanding overview of such an important topic that we all face every day. We have about 9 to 10 minutes for questions, and there are a few in the Q&A and one in the chat. And if you would like to come in and share your question in person, please raise your hands. So there's a question from Imran Setia about how do you define or diagnose really those patients that fit the SOFA, but actually you think that there's an infection, but you cannot really pinpoint an organism, and those who are with other conditions like pancreatitis and the other conditions that can actually cause a SOFA score.
So Imran, you highlight 2 issues. The first is finding the bugs. And it is a huge issue. We still know probably up to 40% of times that patients have an infection, we never identify the organism. It's a limitation of our culture methods. It's a method of timing. We did a pilot work in the ICU when you're just looking at ventilator-associated pneumonia. Some of it has to do with our culture media. When we did expanded culturing over in Mike Surrett's lab on campus, we were able to identify pathogens that maybe we don't get with our current culture methods. And Cheryl and I have been working with this, trying to see if we can improve our diagnosis. We have some of the most sophisticated culture equipment in our labs right now, but it still is a gap. The other thing that I would get people to think about, so let's take a patient who comes in with a myocardial infarction, has a period of shock, or as I see in ICU West, a period of hypotension associated with surgery. What I think we underestimate is the period where there is gut translocation, and we may not always identify those anaerobic bacteria that may be responsible for infection, similar as we don't identify those organisms that we often think of as commensal, but there is data to support that things like some of the commensal flora down deep in the lung may be responsible for infections. So that's the first thing. And then the next thing is really thinking about what are the causes for that organ dysfunction. So I said that the specificity coming out of that database was about 79, 80%. We really need to think about the other causes. Okay, hope that answered the question adequately. I would still report it of sepsis, cause unknown, suspect the following, but it is a challenge, I admit. Okay, Punji has a question, 2 questions. What are we doing about the antibiotic to prevent the blunderbuss or the shotgun approach? So for those of us who live in the ICU, antimicrobial stewardship is a twice a week event. I'm not sure that the AMR team has, in the midst of COVID, has had any big spread about that, but it is an issue thinking about the length of antibiotics. There's a number of studies ongoing. The balanced one is the one I can think about how long do you need to be on antibiotics. And then the second thing I would think is if you've got a culture, simplify the antibiotics and switch to oral as soon as possible if that patient is getting better. But definitely when those patients are looking septic, I don't think we have much choice many times to other than to hit the big gun. The other thing that I think our ID colleagues have been concerned about, particularly in COVID, is the use of antibacterial antibiotics with no great evidence that it makes any difference. There is more data coming out that the use of azithromycin and ceftriaxone in COVID patients, even when they're sick, may not have benefit because COVID is a dominant organism. We do not have the urine pneumococcal antigen test. and availability of Legionella. I'm hoping, at least in Hamilton, I've seen 2 Legionellas in the past couple of years. So I think it's relatively rare. Punji, you can argue with me. But, you know, I'll bring that back to our ID colleagues about what tests are the best, and the use of PCR-based tests to identify pathogens more rapidly. I think it's coming, but, you know, the investment in that equipment to be able to use some of these BioFire tools, I won't say they're perfect, but they're coming, and as are the ability to use PCR-based tools to identify antimicrobial resistance genes quickly. Herzl's asking me what percentage of sepsis is viral. Good question, Herzl. Right now, I would say it's large in the midst of COVID. But in general, it's really seasonal. You know, we haven't seen the same amount of flu this year, but I would say during the winter time, a significant proportion of what we see admitted to the ICU are respiratory viruses, whether it's rhinovirus, enterovirus, or, you know, influenza. COVID seems to have overwhelmed everybody this year, but that tends to be more seasonal. And then any time of the year, it could be bacterial. And then really the fungal infections, I often think of them as secondary. There are the fungals occur in people who have had intra-abdominal wounds, have had, but they're a big source of missing those fungal infections and being aware and thinking about that. You know, patients who are on chronic TPN, we tend to think about fungal infections. So yes, viral sepsis and fungal sepsis may be a smaller proportion compared to the bacterial, but I would say what we're seeing in our community is an increasing incidence of MRSA pneumonia coming from the community, for example. I've seen that. We just need to be mindful of that in our patients. And then really the wound infections, and thinking about the fact that we've seen group A strep even this year. And so the strep infections, and strep, you know, it was a bug that for many years was, didn't know how to acquire antimicrobial resistance genes. But I think, you know, now almost 100 years of antimicrobial pressure or antibiotic pressure, even that one's getting a little smarter. Maybe not as smart as Pseudomonas, but Pseudomonas seems to be the greatest thing. Okay, Maureen's asking about Epic Odyssey. Good question, Maureen. The infection working group, I think I'm meeting tomorrow with Dominic and a bunch of us to start looking at what Epic has in terms of infection recognition. Here's what I know about the gaps. Epic uses Muse. Muse is the worst of the early warning scores. We are hoping we're going to be able to keep Hughes, because we know that the addition of delirium into early warning scores, both us and the UK, has improved the sensitivity and specificity of that score. We know that using and measuring oxygen as part of all of that is important. Epic has some proprietary stuff in there, but they are still basing it on SEP1 definitions. They still use SIRS in their algorithm. And I'm not sure that while it may be helpful for picking up infections, may not help us with sepsis. And so that was one of the reasons I really took that Iatrix platform, which in the US had been based on SEP1, and made it into a SEP3 definition, so that we continue to move along with the research evidence. Will we have a new definition for sepsis? Probably. The challenge is getting those EHRs to be nimble, to move along with what's happening in the sepsis literature to improve the definition going forward.
Awesome. There's another question from Dr. Workington about the identifying liver dysfunction using ALT versus using bilirubin level. It came up in the chat.
Yeah, so good question, Ted. So here's the challenge. Bilirubin is, as you know, one of the most molecules, demonstrates the complexity of making bilirubin. And so when that audience created that score and put bilirubin in there, we were really thinking about the function of the liver as opposed to hepatocellular damage. And so that's why bilirubin, both in the SOFA score and in John Marshall, our Canadian-owned made mod score that we use as part of our CSIS data, Both put bilirubin in there because they thought it was a better value of the complexity of the hepatic function, knowing that that was one of the first things that went down. Is it perfect? No. Does SOFA and or MODS need to be revalidated? Possibly, but it was the reason that they chose bilirubin.
Awesome. It's exactly at 9. All questions are answered. Dr. Forster, thank you so much for this and great engagement. And hopefully we can move on continue to reduce sepsis in hospital. Okay. Have a good day, everyone.